My name is Yuan Xijia from the National University of Singapore. I'm happy to present our study with a very long title. It's called Comparison of the Effect Estimates of the Same Outcome between Randomized Clinical Trials that designating it as a primary outcome and those designating it as a secondary outcome, a meta-research study. When designing and conducting RCTs, researchers may focus more on the primary than the secondary outcomes. When RCT is manipulated for positive results, the primary outcomes may be overestimated more than the secondary outcomes. For a given outcome, its effect estimates may be larger when it is used as a primary outcome than when it is used as a secondary outcome. Such discrepant effect estimates may indicate the impact of bias. So the aim of the study was to compare the effect estimates of the same outcome used as a primary outcome versus a secondary outcome among similar RCTs. This meta-research study followed a retrospective cohort study design. We identified similar RCTs that assessed the same outcome. The RCTs using this outcome as a primary outcome were considered the exposure group and referred to as PO-RCTs. And those using this outcome as a secondary outcome were considered the control group and referred to as SO-RCTs. The effect estimates of this outcome were compared between PO-RCTs and SO-RCTs. Because RCTs in the same meta-analysis have similar designs, in this study, we relied on meta-analysis to identify similar RCTs. The example meta-analysis compared statins with placebo on mortality among patients with coronary artery disease. The RCTs using mortality as a primary outcome were considered PO-RCTs, and those using mortality as a secondary outcome were considered SO-RCTs. We included meta-analysis from Cochrane reviews that assessed the efficacy of health interventions and were published between 2021 and 2024. We only considered RCTs that recruited patients after 2005, when RCTs were required to be registered. In addition, eligible RCTs should define primary outcomes and use a negative control, such as placebo, sham, or no intervention. In this study, we took 3 steps to calculate the effect estimate. First, we transformed the risk ratios and the mean differences from meta-analysis to odds ratios. Second, within each meta-analysis, we calculated the ratio of odds ratios between PO-RCTs and SO-RCTs. Third, we combined the ratio of odds ratios across all meta-analyses. In the primary analysis, we compared PO-RCTs and SO-RCTs among all eligible RCTs. In addition, we performed the comparison among prospectively registered RCTs because the pre-specified outcomes might be changed in the final reports of RCTs. In the subgroup analysis, we assessed the impact of blending as an effect modifier on the ratio of odds ratios. So far, we have screened 800 Cochrane reviews and identified 154 eligible meta-analyses with 1073 eligible RCTs, including 553 PO-RCTs and 520 SO-RCTs. Among all 1073 RCTs, PO-RCTs produced odds ratios about 1.27 times larger than SO-RCTs. Similarly, among 372 prospectively registered RCTs, PO-RCTs produced odds ratios 1.21 times larger than SO-RCTs. Among RCTs with a high or unclear risk for blending, PO-RCTs produce significantly larger odds ratios than SO-RCTs. For example, among RCTs with a high or unclear risk for performance bias, PO-RCTs produced odds ratios 1.48 times larger than SO-RCTs. Among RCTs with a high or unclear risk for detection bias, PO-RCTs produced odds ratios 1.44 times larger than SO-RCTs. And among RCTs with a high or unclear risk for both performance and detection bias, PO-RCTs produced odds ratios 1.60 times larger than SO-RCTs. On the contrary, among RCTs with a low risk for either performance or detection bias, we did not find significantly different odds ratios. Our study shows that the effect estimate for an outcome may be larger when used as a primary outcome than a secondary outcome in RCTs. And these discrepant effect estimates may be at least partially attributed to bias. Our study had several limitations. For example, Cochrane reviews cannot represent all systematic reviews, and some RCTs in the same meta-analysis may not be comparable. And publication bias could not be assessed in most meta-analyses due to too few RCTs included. Our study shows that the comparison between PO-RCTs and SO-RCTs may be a new method to detect potential bias in evidence synthesis. Researchers conducting evidence synthesis may need to note if an outcome was designated as primary or secondary in RCTs, and perform sensitivity analysis and interpret results considering the potential impact of bias. And also, prospective registration and the reporting of primary outcomes should be further improved. And this concludes my presentation. Thanks for your attention.
Thank you for a very efficient presentation, leaving plenty of time for questions. Does anybody want to stand up first before I fill it with my question? Okay, we'll take John first, pre-identified in white.
Thank you for a great presentation. I'm wondering how confident you are that primary outcomes were really primary outcomes and secondary were secondary, because if someone wants to highlight a result, they may say that this is our primary outcome. And, Ben Goldacre's work has shown that even in the most visible, most prestigious trials, switch in outcomes or in analysis is very common. So maybe what we see is that a nice looking result gets presented is more likely to be presented as a primary outcome.
Yeah, thank you for the question. Yes, it's very common for researchers to switch the outcomes. So that's why we perform the second primary analysis. We can see that the difference does drop a little bit, which implies that the switching of outcomes may have some impact on the comparison between those two types of RCTs. And that, yeah, I agree that it's very common for trials to switch outcomes.
Okay, we'll move to the back there.
Emmanuel from Karolinska in Stockholm. Even if they're prospectively registered, they can switch. And maybe you can look that up in clinicaltrials.gov and kind of backtrace it. It'll be very interesting because that would form a natural control group, those that did the switching or the outcome that they switched away from to the new outcome. I was wondering, does it differ between the surrogate outcomes and like mortality or harder clinical endpoints, this effect that you're seeing in primary and secondary?
Yeah, thank you. It's a very nice question. And we did perform a subgroup analysis based on the type of outcomes, like hard outcomes like mortality and hospitalization, and also like the surrogate outcomes like blood pressure or something like that. We did find that the difference between the PO-RCTs and SO-RCTs is almost undetectable among trials using mortality as the primary outcome. But for trials using like some surrogate outcomes, the difference is larger. It's like more obvious. I think that's maybe because like when you do a trial for like the outcomes like mortality, maybe hard to do something about it. If you want to.
The back and then in the front here.
Hi, Ioana Cristia Padova. Great presentation. My question is related to what John and Emmanuel asked. Have you looked for these prospectively registered RCTs at what they had actually registered as primary, and take separately those trials that change between registry and publication, downgrading, for example, the primary outcome to secondary? And is it possible, had you looked at that, would it be possible that in fact a lot of the results maybe are driven by exactly the people who selectively reported, so at the end or during the analysis chose to upgrade the secondary outcome or downgrade the primary?
Oh, thank you. Yeah, for this analysis, we only consider, we classify the outcomes based on the first version, based on their prospective version. For example, a trial like may define a primary outcome in the first place, then it changed, like several years later, after recruitment started. And in this case, we only consider, we consider the first outcome registered as the primary outcome. So even if it is switched, to secondary later on.
Okay, thank you. Front of Mike.
Hi, Jen at Sage Publishing. More of a simplistic question, but what made you want to explore this?
Sorry.
Why did you want to explore this?
Oh, I think this can be like a new way for, to assess bias in meta-analysis. Yeah, and like the current methods to assess bias is based on like, for example, like randomization and allocation concealment and blending, something like that. And I think that may not be like very comprehensive. Like from like this way, like we could compare trials in the segment analysis with different features. Yeah, we can like maybe we can have like a more comprehensive sense of the bias there.
Thank you.
Yeah, thank you.
Since we have another minute or two, I'll ask a question. I wasn't clear whether you were comparing studies with the same exposure for that outcome. Are we looking at the same exposure outcome pairs or different ones?
Oh, the same one. Yeah, because
same drug.
First, we compare the trials within the same meta-analysis first. So which means they are matched by PICO. Should be.
Great, thank you.
Yeah.